Thank you very much. A follow-up question somehow linked to this is maybe also it has been stated by you and by the professor that you need clearly collaboration, coordination between different stakeholders, governments, leaders, patients, health workers, you name it. What does WHO do to encourage that, to bring these stakeholders closer together?
So fostering collaboration partnership is, of course, one of WHO's core functions. And WHO has developed several mechanisms to ensure this at all levels, global level, regional level, national level as well. And in an informal way, I would say that to facilitate a direct communication between partners and member states and organizations and individuals as well, the Global Patient Safety Network, which WHO has established, has provided a hugely important platform. And I've got feedback from our partners that if we did not have Global Patient Safety Network, World Patient Safety Day would have not been successful at all, because it really resonates with all the members and all who are key stakeholders who are actually taking action are on the Global Patient Safety Network. Then WHO has a mechanism such as WHO collaborating centers, as well as WHO partnership with non-state actors. So there are many formal mechanisms as well. And for patient safety, we work with across the board, all organizations who have a stake in patient safety. To name a few, we work very closely with the International Council of Nurses, the Council of Midwives, and World Medical Association, as well as WONCA, which is the organization of family physicians, and as well as the International Society for Quality in Healthcare, patient organizations, particularly International Alliance of Patient Organizations. WHO has also launched a very important network, which is a unique network, a Patients for Patient Safety Network. And some of the participants and speakers today and leaders today on this in this meeting, in this forum, are actually very much engaged in this as well, Dr. Manvi in particular. So we have the Patients for Patient Safety Network, which brings together patients and family members who have some experience of harm in healthcare, and how they share their experiences and their learnings and how things should be done in a better way, so that when we are developing our systems, we look into mechanisms of improvement. Recently, we have also had mechanisms such as MOUs with several organizations and partners, so that WHO can have more concrete mechanisms of working. With the WHO headquarters had a recent MOU with Singh Health as well. So we are working very closely as partners, and the activities which Professor Tan mentioned, particularly just 2 weeks back in Singapore, was a capacity building activity of inter-country capacity building, where several participants from countries were invited, and we worked together with the Singh Health and Institute for Patient Safety Quality, together with WHO at all levels of the organization, global, regional, and country office, to build capacity and work with countries. I must say, I think WHO truly works as one WHO in patient safety in particular, working at global level, regional level, and country office, so that we can directly reach out to countries and create networks at all level. One of the indicators you would have seen that National Patient Safety Networks is one of the core indicators of the Global Patient Safety Action Plan. And several countries we are working with, they are now establishing national patient safety networks, which again bring together all the stakeholders and partners. So they are formal mechanisms, they are informal mechanisms, they are one-to-one mechanism with different organizations, multilateral, bilateral, and particularly non-state actors in official relations. All the organizations who work on patient safety are already in official relation with WHO. So we reach out to them. Any consultation or ministerial summits. Joint Commission International is another partner, Patient Safety Movement Foundation. So several partners are working on patient safety related leadership role. They're all part of WHO's collective work on patient safety.
Thank you very much. Professor Tan, another question for you. In your presentation, you very clearly outlined everything that Singapore has been doing, and as I said, it's really impressive. Now, based on that experience, for countries that aren't that far yet, what would be your advice as to where to start? Maybe what is the easiest thing to implement first? And then the opposite question, in your experience, what has been the most difficult part to implement?
Right. Actually, it's basically there are three aspects. One is the leadership, the other is the culture, and the other is the system. So I think whether it's in the high resource country or the low resource countries, you need to be able to tackle this. And the formula is the same because you need to have leadership commitment. You need to have the mindset of the culture of patient safety, target zero harm, and you need to create a system of high reliability, right? And a learning system. So within your resources, you will try to create that. Depending on at what level you are, I think it's an achievement if you can bring it to better and getting better. There's no perfect system. Even in Singapore, we still have harm, see, but we try to reduce it. In fact, in the high resource country, there's an issue of very complex care, and there's issue of high cost care as well. And that itself is actually harm as well. Whereas in the low resource country, the cost may not be that prohibitive, and there may be simple solutions that can do that itself. So I always say that the principle is still the same, but it's a matter of contextualization to be able to do that. So it's similar. The leadership, the culture and system is similar. It's the contextualization that you need to vary depending upon at what level you are itself. Right? Yeah.
Thank you very much. Dr. Neelam, maybe the last question because we're slowly running out of time. From your presentation, it's clear that this whole area of patient safety is a relatively new field of work. You pointed out that like 20 to 10 years ago or so, the basis was put in place, but actually the real acceleration is only in the last 5 to 10 years or so. My question is, why so late? What has taken so long to bring this very, very important work to the forefront?
Thank you. I think that's an extremely important question of, how countries perceive patient harm and how countries are prioritizing action on patient safety. So the first resolution actually was driven by To Err is Human, the very first report. So I would say the birth of patient safety as a discipline was late in 1999. To be precise, it was 29th of November, 1999, when To Err is Human report was launched, which is Building Safer Health, health systems. And this IUM report alerted countries around the world, particularly it was a US report, the harm which is happening in healthcare, which is simmering but not really coming up as, something very important. So it was happening all the time, every health facility, but seen as isolated events, no mechanism of learning, no mechanism of actually putting in place, some improvements, what we learned from what has gone wrong. So after 1999, the first time the World Health Assembly at the global political leadership took up the topic of patient safety in 2002. The very first resolution was in 2002. And they were, the World Alliance for Patient Safety was launched. Several countries prioritized patient safety, started national agencies on patient safety during the foundation phase when patient safety was identified. However, somehow over a period of time, it was sort of seen as something static, like we've done it. Some countries did it, others, for some time did some uncoordinated efforts. But slowly and slowly that momentum, was lost and died down. It was seen that in some of the high-income countries was seen that the problem of patient safety is resolved because we had a resolution, we took some actions for a couple of years, and now it should have been already institutionalized. While that did not happen because we are in a complex adaptive system and, everything changes in health system, the complexity, the technology, sophistication is changing. And slowly, the political leaders themselves realize that this is something which is really affecting our journey for universal health coverage. Huge burden of litigations coming to, to governments of unsafe care and distrust in health systems. So all this combined of, looking into actual economic costs, the loss and the wastage of resources by just compensating not in terms of money, but the huge, human suffering and the catastrophe impact on human life, that was really recognized by political leaders, which led to a rejuvenation. And the actual, concrete, I would say, although there were efforts by many organizations for several years, concretely, when the political leader got engaged through the ministerial summits in 2016, that is when a second wave of, I would say, global patient safety movement started. And since then, it is now almost these are annual ministerial summit series where political leaders and healthcare leaders meet together. So I would say why it was delayed, because it was not sustained, and the solution which were put in place were not sustainable, and political leaders and healthcare leaders somehow presume that patient safety is now institutionalized, while it was not. And the complexity and the dynamic nature of the provision of care and the actual the harm which happens in healthcare was not really recognized. Now there's a growing evidence on this, so the evidence actually speaks for itself. And actually that links also to the previous question which Professor Tan was answering in terms of where do we start with. So to build a case at national level and even in hospital level, if we need to convince our leadership that this is an issue and it needs to be prioritized, we need to do some sort of build a case and look into what actually are the issues, some sort of burden of harm, looking into what is the reality in my facility or my country. And that actually can help in building a case. OECD has published a series of publications on economics of patient safety, which can provide a very good basis also for building a case for patient safety. And if we want to really prioritize one programmatic area where we can say, if you take action in this area, it will lead to significant reduction in harm, I would say medication safety is one area which can be prioritized. Because more than 50% of preventable harm happens because of unsafe medication practices and medication errors. And if you want to start small, look into how developing a campaign for patient safety, for medication safety, like no check ask, and even simple tools like 5 moments for medication safety could help in taking action in improving medication safety.
Thank you very much, Dr. Neelam. One last question from on-site. Mr. Manveer has a question.
Sorry, thank you so much. My question is directed primarily to Dr. Tan. I'm presenting with you tomorrow, but my question is, you mentioned just now in your presentation that there are courses available to healthcare staff where they can do diplomas or even a master's. Is this open to patients to be able to take this? So a non-healthcare person, I'm saying very loosely here, non-healthcare, non-doctor, non-nurse, but a patient who has been a part of the system for many years, because you obviously, people have got long-term illnesses, have been a part of it. They may be engineers or so on, but are not taken seriously because they're deemed to not have proper healthcare background. So are these masters or other subjects like that open to patients so that they can enroll in them, be certified, and then go into the system to have a fresher look at it? Prof. Tan first, or maybe WHO wants to chime in on this as well. Thank you.
So thanks for the question. I think this is a very important question. As you know, in Singha, we have actually have a group of very active patients who are becoming our advocates. And when they become advocates, they actually train themselves. And we actually created a course called a Patient Advocacy Communication Training course. So all of them went through this. And a lot of them who wants to get involved in certain projects, they will attend our quality improvement and risk management aspect. And because they are SPAN members, our own members, and they're helping us, we actually provide them free of charge to be able to attend these courses. Our master's course and the diploma course are actually meant for people who want to have a career in patient safety. Well, if a patient wants to have a career in patient safety, it can. But there's a qualification. It must have a basic degree, a bachelor degree. And then we interview and then identify whether that person can commit to the time, because we are doing a diploma, that you need to have time commitment, and you're doing a master, you need to do a thesis itself. If you have that capability, anyone who have a bachelor degree are welcome actually to go into the course itself. And this is actually meant because there are also people want to switch career. I have a person who is from from the oil and gas industry, and they want to change career because they are on the risk aspect of the oil and gas. So they decided to enroll into the course. It could be anyone who is interested in patient safety and who wants to play some part in patient safety, because we give them the basics about patient safety, which is a new science. Thank you.
Thank you, Professor Tan. I don't know, Dr. Neelam, if you want to add something to this. Yes.
Yeah, absolutely. So two approaches we are using now for building capacity of patients and families, and also patient advocates. We actually are developing a course under WHO Academy, which is a very systematic course. It's Patient Safety Essentials. And it will have modules for different target audience, for nurses, for patients, and for health workers, for healthcare leaders as well, policymakers as well. So, a basic level of patient safety understanding in different topics. And that's really something which I think we should look for, and would really encourage and promote individuals and families and patients to register for these courses. It will be, of course, free of cost with certification. But this is something in progress. In addition, we also are developing a course for a 3-day course or a 5-day course. We're still working on it, not really finalized, for developing capacity of those patients and families who actually are contributing also as advocates. So they are like Mr. Manvi himself is a very strong patient safety advocate. So having more and more patient safety advocates, the training is in a different perspective. And it's what role and how they can take it forward at policy level, and in building a case for patient safety around the world, becoming the voice of patients, elevating the voice of patients. So both these specific capacity building approaches we are going to take, and I would welcome members from this forum who would like to be engaged in this process with WHO, because both these projects are in the formative stages.
Thank you very much. Dr. Neelam, Professor Tan, really thank you for your contributions here. This has been very, very informative. We've gone over time. I think there's an indication of the interest that there is in the topic. And with this, I want to give the floor back to the organizers. Again, thank you for both of you for your contributions, and back to the organizers.
Thank you very much for this opportunity.
Thank you.